Hi, this is Elliot Fishman, and welcome to part 2 of our series on renal tumors, going beyond renal cell carcinoma, pearls, pitfalls, and key diagnostic findings. We left off last time. We spoke a bunch about non-contrast CT and the importance of non-contrast CT in helping us understand where a lesion starts from in terms of attenuation, with lesions under 20 Hounsfield units or over 70 and well-defined, likely being benign. But now you have a lesion that's not below 20 or above 50 or above 70. What do we do? Now, I mentioned before the average renal cell carcinoma measures about 37 Hounsfield units on non-contrast CT. So now we can look at the kidneys. Now, it's important to recognize, I always like to think about it, whether we're looking at tumors or infection, whether we're looking at inflammatory disease, whether we're looking at neoplastic disease. The way we give contrast and the timing of the contrast will really determine both our ability to detect lesions as well as our ability to be very discriminatory as to what the lesions are. A specific lesion in the kidney, if I look at it at non-contrast, or I look at it at 30 seconds, or I look at it at 70 seconds, or I look at it at 4 minutes, will look different. Each of those different time points will give us different information, and putting all that information together really allows me to make a very specific diagnosis. So let's first talk about cortical medullary phase. Some people call this the early phase or the arterial phase. It's usually between 20 to 45 seconds after injection of contrast. Remember, we like to inject contrast at 5 cc's a second, usually around 100 to 110 cc's of Omni 350, for example. When we typically talk about cortical medullary phase at Hopkins, we typically talk at about 30 seconds post-start of injection. At that point, the cortex is maximally enhanced around 150 Hounsfield units in a normal kidney, and the medullary enhancement is lower, typically around 50. So there's usually around a 90 to 100 Hounsfield unit differentiation between cortical enhancement and medullary enhancement. And last year we have a whole lecture talking about cortical medullary differentiation and what the importance of that is and what causes the differentiation and what happens when that differentiation doesn't occur. So the things we look at is from a detection perspective, from a classification perspective, how the lesion behaves become critical. Now, the cortical medullary phase to me is optimal for looking at arterial structures, and whether that's for preoperative planning, whether that's for renal donors, whether it's looking at lesion vascularity or neovascularity, whether it's looking for changes in perfusion in the kidney, whether it's looking at the earliest signs of AV shunting, or some tumors which will only be seen in that early phase acquisition. This article is a bit older, but does make the point that cortical medullary phase is the ideal phase for helping you distinguish specifically what a lesion is. Most clear cells are around 152 Hounsfield units, and papillary in this article was around 62. That's about a 90 Hounsfield unit gap. So we talk about, and as we look at it further, if a lesion is under 90 Hounsfield units on cortical medullary phase imaging, it's going to be likely a papillary, and above 100, a clear cell. So here's an obvious mass in the right kidney. There's some faint calcification. We know it's going to be malignant. This is not a benign cyst or a benign lesion. You can see the prominent vascularity in the patient's right kidney, very nicely shown in this 5-centimeter mass. And there it is nicely on the coronal view. So you can see the early phase imaging shows you a bit of the renal artery, shows you the cortical medullary differentiation, and the lack of cortical medullary differentiation where the mass is. This also explains why sometimes very small tumors will only be seen in a cortical medullary phase. But this is a solid hypervascular mass. By the time we reach the excretory phase, the mass is solid, it's enhancing, but it's washed out. and this is a clear cell renal cell carcinoma. Now, when you take the arterial phase, you can create with cinematic rendering 3D maps that show you the interface between normal kidney and tumor, and the fact this lesion is vascular, the contralateral kidney is normal, and this is a clear cell renal cell carcinoma. Here it is from a posterior projection. There's the solid mass, the vascularity, nice surface of the right kidney, and again, taking all of those images together is what a surgeon would do in this patient when they plan on doing a partial laparoscopic nephrectomy. Same article. Cortical medullary phase attenuation values of clear cell were higher. We said 90 Hounsfield units. And in this article, the accuracy was 95.7%, sensitivity 98.3%, and specificity 92% when using 100 as the cutoff value. That means a lesion under 100 they called papillary, above 100 they called cortical medullary. Attenuation as representing a clear cell renal cell carcinoma. Now, yes, I've seen a couple cases of papillary over 100, but it's exceedingly rare. And yes, I've seen a couple cases of clear cell under 100, but this 95% plus accuracy is totally our experience as well. Now, another thing to look at is the information about vascularity of the lesion. We think about that as a good separator, but also it tells us other things, because lesion vascularity, as we've learned with AI, can really tell us a lot about the cytogenetic characteristics of clear cell renal cell carcinomas, which may affect patient prognosis and also potentially predict what chemotherapy and, for example, what molecular targeted therapies a patient should get. The natural history of clear cell is variable, with some tumors exhibiting an indolent growth pattern and others an aggressive pattern, including local recurrence after resection with distant metastasis. Histologically defined tumor necrosis in clear cell has been shown to be an independent negative prognostic factor for metastasis and overall survival. In fact, histologically defined tumor necrosis is integrated into prognostic scoring systems such as the stage, size, grade, and necrosis score. So one of the things we also recognize, the information we get from the vascularity of the lesion is not just simply papillary versus clear cell, but it's also telling you a lot about the tumor. So in this patient with clear cell, vascular lesion, large mass, this patient would not get a partial nephrectomy, but also the tumor has a lot of central necrosis. By having a lot of central necrosis, what it means is this tumor is more aggressive and this patient will need aggressive management. You can see the neovascularity. Neovascularity is important, but central tumor necrosis may be more important. Now, you can typically see the central necrosis across all phases here as we go from arterial to venous, and as we go from venous to excretory, the central necrosis is there. So for the clinicians managing the patient, they know in addition to nephrectomy, we'll have to really think about the chemotherapy regimen. Because of this central necrosis, this tumor is aggressive, and if not, the tumor will recur locally, and distant spread will also occur. And again, here's that central necrosis seen on the excretory phase imaging, so it's seen on all phases. Here is the cinematic rendering, show you the central necrosis, very nicely shown on the cinematic rendering. Another patient, very vascular lesion. This is a clear cell. It's also very large. You can see there's involvement of the patient's renal vein. There's lots of collaterals near the kidney. As you look at a few more of the axial images, you can see that the pancreas is pushed forward, but look at the neovascularity of the lesion on the coronal 3D maps. Look at some of the nodes that are present. This is a clear cell. The nodes are also typically hypervascular. Clear cell rather than papillary is more likely to invade the renal vein. Here you can see very nicely the extent of the tumor. Now, in terms of renal involvement, particularly when the lesion has vascular thrombus, you can see the thrombus in the IVC and in the renal vein well on the early phase imaging, but in most cases, the venous phase is going to be ideal. Here's a venous phase in that patient showing you the renal vein involvement, and then you want to look carefully to see whether or not there is also IVC involvement. Again, nicely shown in the cinematic rendering, as well as looking at the adenopathy, which is vascular. A really nice example of an aggressive clear cell renal cell carcinoma. Now, on the cinematics, I showed you the 3D imaging. A good article by Rowe talks about how 3D is very valuable, not only in staging patients, but preoperative planning. Cinematic rendering becomes very important in determining what patients can or cannot get partial nephrectomies, also potentially for looking at tumor necrosis. And we think there are other bits of information we can get because, remember, as opposed to looking at routine axial coronal images, cinematic rendering tells you a lot about texture, and texture tells us a lot about patients' tumors. So that's clear cell. What about papillary? They're typically smaller, but don't always need to be small. They're typically lower grade, usually hypovascular, can be multifocal or bilateral. They have a better prognosis than clear cell, and they're ideal for nephron-sparing surgery. One of the reasons it's good to be able to predict what's a clear cell versus papillary. If a lesion is at the periphery of the kidney, lower edge, you're going to do a partial nephrectomy regardless. But if a lesion is more central, if you believe it's a papillary, you're more likely to do a partial. If it's a clear cell, you're a little bit concerned about margins. And so helping you make decisions becomes very, very important. This article by Hertz from a while back, talking about the fact that papillaries are hypovascular and homogeneous. And this article has stood the test of time. Again, putting those articles together, smaller, smoother, less vascular. Now, I mentioned they're not always small. Here's a 6 centimeter lesion that measures all of about 38 Hounsfield units. Remember the article, 37 is the magic number. For RCC, this is 38, right on that magic number. When you give contrast, the lesion enhances a bit. There's faint calcification, but it's well-defined and sharply marginated against the rest of the kidney. There it is on the excretory phase imaging. This patient is a great candidate for a partial nephrectomy. Again, could this be a clear cell? You would be thinking clear cell based on size, but based on vascularity, you have to go with a papillary renal cell carcinoma, and this was a papillary. Here's some of the 3D renderings with classic 3D, and here it is with volume rendering. Again, preoperative planning. This patient did a partial nephrectomy and has done very well ever since. Now, when we talk about the parenchymal phase or the nephographic phase, that's about 60 seconds out. It's the ideal phase when we look at things like the renal vein. When you want to look at true vascularity or neovascularity, the arterial is better. When you want to look at the calyces, the excretory is better. But that parenchymal phase is very good, particularly for looking at venous structures and looking at some of the washout change from the arterial phase imaging. I mentioned that you can see extension to renal vein or IVC on arterial phase, particularly when lesions are very vascular, but on arterial phase you'll often have flow-related changes. On venous phase you won't. So with CT, venous phase imaging is over 95% accurate in determining the location and extent and spread of thrombus in the renal vein or IVC. And this article by Guzzo made the point that CT does not miss tumor thrombus as this thrombus extends into the renal vein beyond the kidney proper. Now, we talk about clear cell, and I mentioned that you can see renal vein involvement. And here's a clear cell, very vascular necrotic lesion. But again, this lesion is going to be, when you see extension into the renal vein or IVC, Typically, it's going to be seen in venous rather than arterial phase, but it can be arterial phase. But again, I'm always careful to look at the venous phase because I don't want to make a mistake. So for example, in this case, right renal mass, is that tumor in the IVC and renal vein, or is it flow? You can get flow from below, and maybe it's just early non-opacification of the IVC in part that's causing the appearance. So this early phase is not going to be good enough. When you get to venous phase imaging, you then see the thrombus in the renal vein. You see the tumor necrosis. You see it extending up the IVC, but not up to the level of the patient's left atrium. So very, very important, or right atrium. Very important to be able to see the extent of thrombus, not only the presence of thrombus and neovascularity. One thing these MIP images show is that the thrombus has neovascularity. Sometimes people ask the question, is it bland thrombus or tumor thrombus? Sometimes you can't tell. To me, it's always going to be tumor thrombus, but to be argumentative, when thrombus is vascular, it's always going to be tumor thrombus. And here, just as we go toward later venous, very nicely showing you the extent of renal vein involvement, IVC involvement, but not all the way up to the top of the IVC and into the atrium. So again, a very nice example. Patient will get a nephrectomy. The surgeon will go and remove tumor that extends into the IVC, but won't have to do a transthoracic approach as well. Now, there are other tumors that tend to be forgotten about, but are important. Chromophobe is about 5% of renal cell carcinomas. Majority of patients are male with the average age of 60, which is the typical age for renal cell in general. Half the patients have no clinical symptoms. The thing about chromophobe is they're not very aggressive tumors, and a 5-year survival is over 90%, and metastases are going to be rare. The tumors are typically hypovascular. They're typically well-defined, homogeneous. We talk about a central scar now. It's always a challenge, central scar versus central necrosis, but a central scar is the classic appearance, usually on arterial phase, but also seen on venous phase. In some cases, again, it can be challenging. One of the things about recognizing something as a chromophobe is you're more likely to get by with a partial nephrectomy if it's a chromophobe. And if the surgeon thinks it's a chromophobe, but they're not positive, they always could biopsy it, and that can indeed be very helpful. The average size of a chromophobe was about 5.2 centimeters. 46% were homogeneous. 85% of lesions were either solid or mostly solid. 14% had calcification, and about a third had a central scar. You can see in terms of attenuation, it looks more like a papillary renal cell carcinoma than a clear cell. It's under 90 Hounsfield units. So very important. Good example, solid mass well defined. From these non-contrasts could be anything. When you give contrast, it enhances. You can see a little bit of a central scar. Now your question is papillary versus perhaps chromophobe. You can see it here very nicely shown, sharply marginated. Here's some of that central necrosis. This ended up being a chromophobe, but I have to admit this is a case where it's almost impossible to distinguish a chromophobe from a papillary renal cell carcinoma. This patient, there's no way to make that decision. Because of the appearance of the lesion, the patient had a nephrectomy, and here's the lesion on the 3D mapping. Comes a little bit too central for a patient to have a partial nephrectomy. Another example, a little bit like the last case, non-contrast, well-defined, solid, homogeneous lesion. With contrast, it enhances, but only to about 72 Hounsfield units. So now we're talking about papillary category or chromophobe. You can see it very well demarcated on both the axial and the sagittal views. Again, that was a chromophobe. Could you distinguish that from a papillary? The answer is no. But in both cases, you had relatively focal surgery, partial nephrectomies, and the patient did fine. Now, chromophobes at times could look more aggressive. Here's a larger mass with calcification. Remember, I mentioned that chromophobes can calcify, so it can be challenging. When you look at this case from non-contrast to contrast, the lesion enhances slightly, but it's irregular and has these calcifications. It looks aggressive to me. Now, could it be a clear cell? Clear cells calcify maybe more commonly, but I still don't like a clear cell because the lesion's not vascular enough. The lesion's not as sharply marginated as the first couple cases I showed you, and this patient's lesion is centrally positioned, and the patient underwent a nephrectomy, and this was a chromophobe renal cell carcinoma. Now, there's another type of tumor that people often will speak about, and that's an oncocytoma. It's not very common. It's hard to separate oncocytomas from other tumors based on imaging. And you can get hybrid tumors where an oncocytoma and a renal cell coexist. So it can be somewhat challenging. Now, the thing about oncocytomas, if you can recognize them, they're relatively benign lesions. So let's do this. Let's stop here and let's start talking about oncocytomas as we begin part 3 in a few minutes. See you then. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.